And the polling question has completed. You may now continue.
Polling question having been completed, we'll go on with our discussion. Our experience in terms of utilizing the technology involves trying to be different based on quality. We have a team approach with the bronchoscopist and the asthma clinic being part of our Lung Institute program that oversees a lot of different pulmonary issues. We have access to severe asthma patients and a strong partnership in the community with identifiers of allergy, immunology physicians, primary care physicians that are comfortable managing their patients but understand they have a subgroup that could do better based on the severity of their disease. We have dedicated roles within the Lung Institute to try and manage both the physiologic testing and seamlessly integrate all the scheduling issues so it's a comfortable, patient-friendly program so they feel like they really are participating in what their care will be. We've been able to champion a new therapy with the hospital administration, and we drive that based on the issue that we seek to be a quality differentiator in the market. So often, market-based issues right now, at least in the United States, are cost-driven. While that may be appropriate to some degree, there's certainly huge needs that aren't being met that drive a lot for quality differentiation. So fighting the fight with the private payers for pre-authorizations is part of doing this procedure. Any new technology has those particular issues. Engaging with the hospital marketing and public relations department to conduct physician referral and patient outreach and develop tools along with what's available to you from Boston Scientific to market the fact that the procedure is available and capable of being done well in your hands. Understand you're really building a program and not so much building just a procedure or adding something to the tick list that you do. This is part of a more comprehensive approach to taking care of pulmonary diseases. In terms of the clinical training, it's very straightforward, and I think the biggest thing that a pulmonary physician needs to have is a really good understanding of endobronchial anatomy. Physician training is on-site and is provided by Boston Scientific. There's a didactic training center that's computer-based, and there's a hands-on training lung model that's been introduced by asthmatics and then Boston Scientific as they acquired them over the years. Proctorship and preceptorship programs with a trained physician is also available as necessary. There's a support care team from the company to try and make sure that you have all the resources available to you and your staff to do the procedure well, and sites that have been identified to be able to be present in terms of seeing how it's done elsewhere or have those resources indirectly brought to you however you see fit. Now I'm going to get into the issue of reimbursement, but before we do that, there will be another push-out on the next slide of a poll question.
And the polling question has completed. You may now continue, Dr. Wilson.
The reimbursement landscape for new technologies in interventional pulmonary medicine is one of those that requires a little bit of commitment. It's no different than any other device introduced into practice medicine. Anything that's new or first in class follows a pretty prescribed and lengthy process, which Boston Scientific has gone through. They are ahead of the game in terms of well-reviewed and peer-reviewed published data. The Medicare has specific codes and payment rates for thermoplasty at this point that are based on some of the data I'll show you in a second. Other payers will look at things as experimental and work through pre-authorization processes that Boston Scientific can help guide you through with their relationship with the reimbursement group they utilize to help with individual physicians and payers getting through the process of getting paid for this. Boston Scientific works with a lot of those payers directly to try and help facilitate better payment landscape for you. Understand up front, though, that any health plan, usually on the device side, sort of just says no to everything. And that's not new to this procedure. It's new to pretty much any procedure at all. And so what you have to understand is that you've got to invest yourself and the patient in the process of a new procedure of getting up to speed with the payer world. If you're entering this environment now, you're entering at a better time than we started 14 months ago. A lot of that groundwork has been laid. What you need to do is you have to understand that you have to communicate effectively, use the templated work plates that are available from the reimbursement group, copy the patient of all your communications. I guarantee the insurance plan is going to send them some letter that's going to say something that you may not like. You should send them what your response to that insurer is too, so they know the full story and they're vested in the process. Approval is likely when the patient is involved and vocal. After all, if they're interested in getting it because there's a good, clear clinical case and rationale to do so, they're going to be pretty good advocate with the payer or maybe their human resources division at their hospital, or excuse me, at their employer. Other reimbursement tips. Realize that some of the best reviews you're going to get is when the insurance plan is mandated to go to external review. That usually doesn't occur early on, so stay committed. Keep with the process. It'll be worthwhile for you and your hospital. Another tip I find very useful, medical directors are usually pretty kind people, and they generally, once you talk with them about most procedures, and they can see that you're legitimate and it's on the up and up and it's obviously data-driven, will make some comments, and sometimes they'll say, this might really work for your patient, but I have no choice to deny this. I've had that said to me more than once, and I'm happy to quote them on it, as I think it helps the case of moving things along, showing that people within the organization understand there really may be value to the procedure and making them accountable for their statements. There are CPT codes for any unlisted respiratory procedure, and that's 31899, and that's how you should code it, even though most of your patients in this particular procedure will not be Medicare patients. Report it just like this with the HSPCS Level 2 codes or HCPCS codes, so that those claim data are recognized and begun to be counted in the process. Payers don't see something in terms of claims, they don't recognize that it's going on. So report it. It's your responsibility to get paid, and it's also your responsibility to continue to build a track record for the procedure in the payer's mind. Coverage is really erratic at this point in time, but there are good reimbursement assets available to you from Bronchial Thermoplasty from Boston Scientific. A hotline is quoted here. Predetermination of benefits and pre-certification through their relationship with the reimbursement group is also available and should be utilized heavily, as it gives you a better chance for success. This disclaimer slide is really intended to sort of remind you that reimbursement discussions are primarily illustrative. Obviously, every healthcare environment is local, so you'll have your own local payers, your own reimbursement specialists, your own legal counsel that you should consult regarding these issues, and this is not intended to be sort of a complete handbook about how it should occur. Generally, though, the take-home message regarding reimbursement is when you follow the process that's outlined and you stick to the template and so forth, you're going to find that the costs are generally taken care of. Building a bronchial thermoplasty program is one I'm going to discuss next, which is a much more interesting enterprise beyond the early fights we have with reimbursement. And moving forward, this is really a multidisciplinary set of skills that I think you and your institution have to employ. So you want to have access to that high unmet clinical need group. If we can do things in pulmonary medicine all of a sudden as interventional pulmonologists, as the last bullet point would refer to, boy, do we have a ton of unmet clinical needs. If you could take all of your asthma patients that had chronic persistent severe asthma and convert them into better pharmacology with less inhaled less systemic steroids and effects, convert them into people who had less emergency room visits, better qualities of life in terms of their ability to comply with work and school and so forth that make life valuable to them, you do it in a heartbeat, and this is the way to go about it. So I encourage all of my colleagues in pulmonary medicine to look at this time as their time, not just with procedures like this, but all of the realm of things that are exploding in interventional pulmonary medicine that invite a lot of new opportunities for high unmet clinical needs. So you want to have access to those severe patients. You want to think about how you're going to identify those in your community with referring physicians, maybe health plans, maybe employers that are larger have the need to make sure that their employees are better cared for, so a visit to their human resources department wouldn't be a bad idea. And look at the fact that there is a new therapy for patients who have that need that's not met. So all of a sudden, the ones that are frustrated, that go to the ER, that go to the doctor, that consume a lot of resources, they have something they can do that's different than what they're currently doing. Identify those people, include them in your program, and evaluate them seriously for whether they're relevant for this particular procedure. And in the whole world of physician marketing, I want to talk about that briefly, but you want to go through the first steps of getting a physician release to participate in the program as you look at getting into doing thermoplasty. Establish a protocol to make sure you receive and handle those patients effectively and efficiently. Sort of a soapbox statement, but there is no particular badge of honor in making patients wait for evaluation. We have a demand management tool carrying open spaces all the time, so I encourage you. Patients think the event of referral, well, no matter how chronic their process is important. Get them in and see them soon. I think you'll find a better life ahead for you, and they'll be happier, and you'll be happier too. Conduct patient database searches for adults with severe persistent asthma. Submit patients for predetermination through the reimbursement hotline that Boston Scientific established. And then I'm going to touch briefly on the thing that is always difficult, educating hospitals and physician networks with media outreach and patient awareness programs. The patient awareness programs and the media outreach aren't so difficult, but we as a group of physicians can be a little difficult. So with doctors, the rule of thumb in terms of awareness, you do it all. You do the hallway conversations, you do the medical staff dinners, you do the physician education programs, you do the grand rounds at your hospital, and you make yourself available to put yourself out there as the person who's able to deal with this patient population and encourage a lot of questions. And look at how you're going to do all of that in coordination with your hospital marketing program. The end result is really worth it. We've been very pleased that this is one of the technologies and a very important one of the technologies that help us distinguish ourselves in the market from other folks trying to practice and treat pulmonary disorders. So this is a highlight of some of the things that we've done in terms of local market releases and so forth that generate a lot of patient referrals. And, it doesn't go without saying that the most potent referral form is personal conversation and word of mouth. So I'm going to move then to questions as they've been accumulating. The staff have been screening them and getting them in order for us to answer. And there'll be a couple of slides after we finish with questions, and I encourage you to continue to ask your questions, and we'll get to those right now.
Great. Thank you, Dr. Wilson. We will now be answering questions. Again, if you have a question, please type it in the Ask a Question text box that's located on your computer screen.
Thank you very much, Dr. Wilson. First question, generally speaking, what has been the impact of the lifestyle of your specific patients after undergoing BT?
We treated enough patients to see beyond anecdotal evidence, but those people have better qualities of life. So the highly motivated bicyclist is no longer having to take days off, is no longer having to cut short training regimens. They're out being able to do the vast majority of those activities without a lot of symptomatic limitation. Most of those people are improving their quality of life, just like those scores show in the trials done in AIR 2 and before that. And that means that they are out doing things that are pretty substantial to them. If they never ran marathons, don't expect them to run marathons tomorrow. But the long and the short of it is motivated patients are getting a lot out of this procedure.
Thank you. And what do you consider is a safe value for FEV1 for a patient to do the procedure?
I think that's a moving target. If the first problem with an FEV1 is that you have to really know if they really have chronic asthma, and I assume the questioner will know that. But a lot of people who have abnormal low FEV1s may have mixed disorders simply because restoring to a more normal or better FEV1 is more characteristic of asthma. I think if people have substantial day-to-day limitation with fixed FEV1 reductions that are pretty low, you might want to ask yourself how much good you might do in terms of using this procedure. It's a hard guideline in terms of an exact number to give you, but if we had somebody who had an FEV1 of 50% of predicted or less, and they had chronic persistent symptoms and they never had that FEV1 greater than that level, I'd begin to question whether or not I'd have a lot of reversibility to offer to their problem.
Thank you. And a quick question on a couple procedure-related things. How long is your average procedure?
Our procedure, when we use a more sedated patient with procedural paralytics, is on the order of 25 minutes or so compared to 40 to 50 minutes with conscious sedation.
And if you could just comment again about what do you see as the ideal patient for this procedure in your practice?
Ideal patient, straightforward. Chronic, persistent, severe asthma. Already had alternative diagnoses excluded. Already on high-dose inhaled steroids, usually also a leukotriene modifier, for sure a long-acting beta-2 agonist, with concomitant lack of control of their quality of life, meaning breakthrough symptoms causing the use of hospitalizations, emergency room resources, decreased quality of life with respect to the activities they enjoy doing or must do, work, school, etc. Those that are motivated in that group, I'll do very well with this procedure.
And another procedure-related question. You mentioned nebulization of lidocaine and albuterol as part of the patient pre-procedure prep. Could you elaborate and comment on the concentration of lidocaine, and do you mix the two medications?
There are a broad variety of lidocaine protocols. What we use is actually not nebulized lidocaine. We will use some oral viscous lidocaine to coat the posterior pharynx before any sedation, and then also some 2% liquid lidocaine on the upper airway and the cricoarytenoid folds bilaterally at the time of procedure. There are people that use 4% nebulized lidocaine prior to the procedure. Honestly, I believe those protocols vary based on every bronchoscopy lab and are not standardized. The use of albuterol prior to the procedure is not something that we do. Other providers do it. The atropine was also mentioned in this slide deck. We do not use atropine just because we don't believe it really reduces airway secretions based on other data. Other people have bias that it does. I think what the message is that you don't really have to alter what you already do for bronchoscopy in terms of your pre-bronchoscopy sedative local anesthetic regimen in the upper airway.
And a question kind of following on your reimbursement topics. How did you answer your administration's questions about recouping costs for the technology?
Well, present with the current reimbursement issue already having been pressed pretty far through with CMS and Medicare, we're at making positive revenues on even the Medicare group of patients to slightly break even maybe. The long and the short of it is you don't have to take the risk for this procedure with the reimbursement methodology that's been outlined by Boston Scientific with third-party reimbursement group. If you're willing to take risk and go ahead and do patients and accept the fact that you might not get coverage afterwards, you certainly are welcome to, but the whole process is actually set up that you can pre-certify everybody. And in the private insurance, non-Medicare, non-government market, you're actually set up for a win where you're very unlikely to have any adverse cost experiences. The only risk you're out is the amount of time that you'll put into, which is pretty minimal if you follow the reimbursement group's guidelines of getting things pre-certified.
And what do you think about the future of this therapy?
I think the future of this therapy is real. Patients are selected appropriately. We haven't had any problems in terms of seeing the outcomes we expected with every patient we've done. We're anxious to make sure we only do appropriate ones. Think about it this way, though. There are roughly 60 thermoplasty programs right now. This company has actually done a quite good job of trying to identify appropriate places to put the technology early on. But they could have 200 or 300 programs right now and probably will in very short order. if you're looking at doing things like this that make a ton of sense based on good data in your market, and you want to be the first one, better get in quick, because that chance is going to rapidly erode if you're not doing this kind of thing or other kinds of like navigational bronchoscopy or other ability to really look at the periphery of the lung meaningfully. I think you'll miss the boat in terms of trying to be market differentiator, and you'll miss the boat in terms of the future of bronchoscopy, which has changed so much in the last 5 years.
And with bronchial thermoplasty being a procedure rather than purely medication, how do you discuss this procedure with your patients who might be candidates?
We tell them exactly that it's not pharmacotherapy, that it's procedural therapy. We describe to them and show them videos of how it's intended and works based on study information and histopathology to reduce airway smooth muscle, where we tell them what to expect as a result of that and make sure they're aware that we know that 5 years out that it's safe, and it's also replicated in terms of effectiveness many years out. So we can tell them those things and then let them help make their own choice based on informed consent, but we definitely focus on the fact that it's a mechanical and not a pharmacotherapy.
And have other physicians in the community been referring patients to you for this procedure?
Yes. Lots of physicians will always have that sort of one or two bad one that they have in their practice that they see all the time, that they hear from all the time. And they'll immediately come to mind as someone that they might want to refer. We'll see those people and happily see them and make sure they're screened appropriately. And if they're not appropriate for this procedure, make sure we get them back and we tell them why, and we help them sort that out. Sorting out bad problems is the best thing a subspecialist physician like a pulmonary physician can do. Nobody wants to really deal with chronic persistent severe asthma if they haven't exhausted all of the potential therapeutic possibilities that might make their life better. I mean, most people see us, frankly, because they want to be better. Most physicians have an intense desire to make sure their patients do improve. Almost all physicians, I would hope. So sorting these out is not that difficult if you're just committed to try and do it. And patients are often referred if you have that attitude, and it's very collegial in your community.
And along those lines for referrals, have any of your patients been on Xolair or allergy immunotherapy?
Yes, we have several patients on Xolair. In fact, we actually go ahead and screen patients when they're seen for thermoplasty referral for their IgE level and whether they're appropriate for Xolair therapy. We find that it's important to get them placed on that if it's appropriate, especially if we identify that a payer may see that as something they'd rather do first prior to thermoplasty. There's no real rationale to exactly the order of Xolair or thermoplasty, but our approach is to find immunoglobulin E patients that would benefit from that therapy and treat them first. And yes, we have treated at least 2 patients that are already on Xolair that are still having breakthrough symptoms despite maximal therapy.
Thank you very much, Dr. Wilson. That really brings us to the end of the questions that have been posed. If you have a closing comment before we end the webinar.
Only closing comment I have is to my pulmonary colleagues, this is your time. It's a repetition of what we saw before, or said before, and you have an opportunity to address one of those things in your practice that's a huge unmet clinical need. Cross this one off your tick list and get familiar with the technology. I think you'll be pleased.
Thank you, Dr. Wilson. This concludes our webinar. Thank you for attending, and have a good evening.